Awesome. Well, welcome everyone tonight. Very excited to host a friend of mine and a new colleague, Dr. Brian Park. So he's our newest hire at Ohio State Neurosurgery, new spine surgeon. Just started 2 days ago on July 1st. So Dr. Park did his residency training at the University of Iowa, which is also where I did my residency training. So I know it's a great place. Then did his fellowship down at the University of Miami with Dr. Mike Wang. Um, so Brian, welcome. Really excited to have you.
Thanks, Andy. Excited to be here. Thanks for inviting me. It's an honor.
Absolutely.
So thanks.
So first, I wanted to just ask a little bit. Tell us about your fellowship down in Miami.
Yeah, no, Miami is very, the spine program has a rich history. That fellowship is, Dr. Wang says it's the largest fellowship in the country. So, you know, uh, Dr. Wang obviously is very well known and there's a lot to learn from just being around him, not just clinically, but just how to uh, become an academic spine surgeon, So great mentorship, very busy program. It was awesome. So
Very cool. So obviously, Iowa is near and dear to both of our hearts, but can you give us some advantages of like doing a fellowship somewhere else than where you train for residency?
yeah, I think fellowship really, if you do it somewhere else, it gives you the opportunity to just see how real like other experts in spine kind of think about things and gives you also a chance to learn new techniques you might not have been exposed to during your residency training. So I just think it gives you a broader perspective and just makes you more well-rounded.
I totally agree. I always encourage our trainees to, our med students to go out to explore other residencies, our residents to go out and explore other fellowships because the point of a fellowship isn't to learn how to operate, it's to polish and to learn little tips and tricks that maybe you're not used to seeing at your residency program. So I do really think there's an advantage of going out there, learning new techniques, learning new tricks, um, and then incorporating that to the base of what you've learned. And so I certainly know from my fellowship, I was, benefited from seeing, different ways of doing things, and I could pick and choose of like, oh, I like this that this person does, I like that this person does, and then incorporate it into the way I do things. So very cool. Well, yeah, well, we're gonna get started with your talk here. So I believe it's on advancements in minimally invasive TLIFs.
Yep, let me share my screen. Do you see the slide or do you see like my whole screen?
Yep, so your slide looks great.
Okay, perfect. So, yeah, I'll be talking about advancements in minimally invasive TLIF techniques. All right. So, I have no relevant conflicts of interest to disclose. Caveat, I will be talking about a industry-specific product. It's not like an endorsement or not an endorsement. It's just an example of technology in the space. So the posterior interbody fusion is a familiar approach to basically all spine surgeons in to access the anterior column of the spine. So you basically avoid the abdominal contents. You can avoid the sympathetics, the lumbar plexus. The anterior lateral approaches are great for certain pathologies, but I think it can be argued that the posterior approach is very versatile. Um, so in 1943, Clower described the successful PLIF, and it was a way to access the anterior column posteriorly, but um, in order to do this technique, you have to retract the neural elements significantly, and as a result, there's a higher chance for a nerve injury, potentially CSF leak, blood loss, etc. So in 1982, Harms and Rollinger described the TLIF technique. It's a unilateral approach through the neural foramen, through Camden's triangle. And as a result, you can access the anterior column with less nerve retraction. And that was great, but as you can see on the picture to the right, this is from an open posterior laminectomy. Just by its nature, I think posterior approaches, you're going to have a lot of effect on the surrounding normal structures, such as the paraspinal musculature. So, in the quest to become more minimally invasive, Foley and Lefkowitz described the tubular TLIF in 2002, and it's blown up. There's been immense technological advancements, whether it's implants, retractor systems, image guidance, visualization, anesthesia, even, all with the goals of improving the workflow efficiency, surgeon ergonomics, but really for minimally invasive, the minimally invasive goal to minimize the surgical footprint for the patient. But there's still limitations to how minimally invasive a tubular TLIF can be. Um, Even if you go as low as 20 millimeters, I think I've heard of people pushing it even further, but I think that's pretty rare. Anyone who's done this, despite all the dilation techniques, it's inevitable you're going to get some muscle creep, and as a result, you have to resect some of that muscle. Um, the dilation of the tissues is the pressure of that is proportional to the size of the tube you're going to use. So a bigger tube, you're going to obviously put more pressure on the surrounding structures. And the reason you're limited to how small the tube can be is because really the necessity of this procedure is that you directly see the end of your instrument, the tips of the instruments to perform this technique safely. Whether you use loops, microscope, just the naked eye, you need to see the tip of that instrument. So visualization, I think, is one of the key limitations to how minimally invasive a tubular TLIF can be. So I'm just going to present a couple cases from fellowship that utilize some technologies to try to improve on this aspect. So first case is a 52-year-old female with mechanical low back pain, right leg pain. She failed conservative measures. And these are her upright x-rays. You can see degenerative disc disease at L4-5 with collapse of the disc space. There's a mild grade 1 spondylolisthesis at that level. And with flexion and extension, you can see there's a little bit more listhesis with flexion. And on the MRI, you can appreciate that although there's not much central stenosis, there is significant right side neuroforaminal stenosis. It's a top-down stenosis, but also I think part of the facet things are contributing to an AP stenosis as well. So this is like circumferential stenosis of the neuroforamen, but it's unilateral, not much central stenosis, like I said, and overall the alignment is not terrible. So we thought this was a great candidate for an MIS approach. So although a tubular standard TLIF would be a great option for this patient, we utilized this system which uses, it's a disposable system, but it uses a disposable camera as well that goes inside the tube. There's a 22.5-degree angle to that camera, so depending on where you place that camera in relation to the tube, you'll kind of preferentially see a certain aspect of the surgical field more. Um, and that camera then projects whatever it's seeing onto this digital screen. So you can see the tube diameter is 15 by 18 millimeters. It's pretty small compared to a standard tube you would have to use with typical tubular TLIF. And the reason is because you're bypassing the length of the tube where the camera are your eyes. So you don't have to see the tip of the instrument with your own eyes through the tube. You can look at that digital monitor, and the camera does that work for you. So for the surgery, we placed a pedicle screw first because this pedicle screw serves as a base for the retractor arm for this tube. And this is just an X-ray with the tube in place. And just some pictures intraoperatively. This is just demonstrating the um, kind of the central part of the decompression. You can see the lateral thecal sac. The camera is placed at the 6 o'clock position, so it's preferentially seeing medially. And when we want to work laterally for making space for the cage placement, we can put the camera at the 12 o'clock position, and you can see how it widens our lateral surgical field, the view for it. And this is just demonstrating the disc work and the shavers and the trial placement. You know, with a tubular regular TLIF, it's sometimes dicey when you do this because it's hard to visualize what you're putting in there. And I've seen cases of CSF leaks in the axilla of the nerve root, etc. But here, you know, you're seeing exactly where your tools are going. So this was the result, and this is preferential placement of the cage towards the side of the stenosis, and the patient did great. Um, so going on to case two, this is another case using a different technique, but this is a 65-year-old female. She had back pain and left leg pain. She failed conservative measures again. And here it's similar, 4-5 asymmetric disc collapse, a little bit of a higher grade 1 spondylolisthesis. It's mobile on flexion and extension. And here's the MRI. Again, not much central stenosis, but she has top-down left side neuroforaminal stenosis. I do want to point out, although both are top-down stenosis, you can appreciate in this case, you can imagine that if you reduce the spondy and restore the disc height, um, that's I think that was the key a reason she had neuroforaminal stenosis here versus the other case that definitely played a part, but you know, without direct decompression of that side, I'm not sure you would have had adequate decompression of the nerve for the previous case. So in this particular case, we thought an endoscopic approach would be a good option for this patient. And the endoscopic approach, at least in this technique, utilizes an indirect decompression for the nerve root. So these are some intraoperative pictures. This is just targeting with the needle. Sorry, I think let me just move this. And then, yeah, and then we put the initial dilator and then a K-wire, subsequently dilate up, put the cannula. We subsequently do all the disc prep work, place BMP because we do rely on that for fusion here. And then we achieve this result, reduction of the spondy, good restoration of the neuroforamen, preferential placement towards the left side. This was a pretty difficult case actually, and that's another talk, I think, but you can see how the iliac crest is high, and that creates challenges in getting the adequate trajectory and targeting for endoscopic approaches.
You mentioned BMP, but what else are you putting anything else in the disc space to help correct the disc height?
So here we use the I mean, I'm sure you're familiar with this, the bag of bones interbody. So we place BMP and then utilize that interbody. So No other grafts or anything that we place. Mhm. So, you know, from open to tubular to the digital tubular to the endoscopic approach, you might be wondering, it's not that much of a difference, just like few millimeters. This is all kind of anecdotal, but I do think these patients, the smaller you go, they tend to do pretty good in terms of recovering faster and just tolerating the procedure well. So, in conclusion, I mean, there's clearly a role for each of the TLIF techniques, including open, tubular, digital tubular, endoscopic. But really, as we kind of saw here, patient selection is key. I don't think you can say all patients who need a TLIF are good candidates for MIS, and even within MIS, a certain technique. But there's continued growth and development of new technologies to try to become more and more MIS. And I think it's exciting that we continue to kind of push the boundaries further and further. So that's all I have for you today. So thank you.
Uh, great talk. I think you know, really highlight some of the advances that have come around more recently in TLIFs. Couple questions. So, like, one is, uh, your cases both showed, grade one, or maybe the second one is close to grade two, spondies. Do you have a limit on how much slip you go after with MIS TLIFs?
Yeah, I think the higher the slip, I mean, first, it becomes more challenging. Um, Second, you want to do everything you can for um, reducing and fusing, so anything, I think like personally, I tend to lean towards, like, if it's a higher grade slip, I would lean towards an open approach. If it's like a mild spondy, I would tend to favor a MIS approach.
Does instability weigh into your decision to pursue more minimally invasive versus more open approaches?
I guess, what do you mean by instability? Like,
That's the $1 million question, right? So, I've had debates on social media and in person about, like, well, what's instability? If you say, well, something's unstable and isn't going to tolerate a simple decompression, well, what is instability? No, nobody can define it. It's one of those things where it's like maybe there's not a good definition, but you kind of know it when you see it. Um, and so, like, is it, a certain number of millimeters of, anterior listhesis on flexion versus extension? For me, I prefer if there's a difference in upright versus supine. So I think I get a better idea of if it's a mobile spondy. If it reduces in supine imaging, MRI or CT, and they listhese more on a upright image. Is it, the second case you showed, I think in the flexion, they start to, almost, they get an angular change at that disc, which obviously some angular change at a disc is normal, but I think the second one really looks, unstable to me. So I don't have a great definition of it, but if you have something that like looks identical, supine, upright, flexion, extension doesn't move at all, but it's a grade one spondy versus something that lines up when they lay down, it slips forward when they sit up. You get like a distraction of posterior elements when they're bending forward. Does one of those bode, better or worse in your mind in a minimally invasive approach?
um, I think it's really, dependent. Like, in my mind, if I can accomplish the surgical goal, minimally invasive, then I think it's a good option. So if the goal is to reduce the spondy, or to uh, if the goal is to reduce the spondy and it's not mobile and it's not going to move without like additional work, then I don't know if that MIS is a good option. But So it really depends on the specific case, I think. Like the case I showed, I think we were able to reduce the spondy and restore that height of the neuroforamen, and th that was the key generator of her symptoms. And um, we were able to resolve that. So it kind of depends on if you're able to accomplish what you're trying to accomplish minimally invasive. So.
Mm. Yeah, I think that's right. And I think I'll do some minimally invasive TLIFs. I like you said, you got to figure out what your goal is. And so, if you have unilateral foraminal stenosis and you can decompress out of the unilateral fastectomy, then you might not need to reduce that spondy all the way. You have bilateral foraminal stenosis, and you're going to rely on indirect decompression by reducing the spondy for the opposite side. Um, then I think if you have instability, it helps you because if they reduce when they lay down or they're mobile, I think it's easier to pull them back. I think if I have bilateral foraminal stenosis and a spondy that does not move at all, supine upright flexion extension, I think that at least what I and you know what I would offer that patient would be an open TLIF because I think I'm going to need a bilateral fastectomy. I think I'm going to need to like really kind of do work on both sides to be able to mobilize that enough to pull it back. And I'm more worried through a tubular approach. I don't do endoscopic, but I do some tubular, and so I'm a little more worried about tubular approaches for bilateral foraminal stenosis if they're real kind of stuck. But I think you hit the nail on the head. I think you know identifying what your goals are, what needs to be accomplished, and then how to accomplish it, whether it's open tube, uh, you know, digital enhanced tubular approach or endoscopic. You know, having those tools in your kit is awesome.
Yeah.
Good. Well, open the floor to any other questions from anyone in the audience. Very good. Well, very good. Everyone, thanks for joining and check out this talk when it gets posted on YouTube. And yeah, everyone have a good night. And Ola, I see you, another Iowa grad on the guest list
Ah,
here.
hey, Ola.
Good. Thanks, everyone.
All right, thanks.
Thanks, Dr. Park.
Thank you.